Welcome to this evening's Twilight Online Seek to Treat Simplifying HCV Treatment in General Practice webinar. My name is Samantha and I am your host for this evening. Before we make a start, I'd like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. Before we get started, I'd like to introduce our presenters for this evening. We're joined by Dr. Joseph Lawler and Dr. Mari Healy. Joseph was awarded his medical degree from the University of Sydney in 2004. He completed his advanced training in gastroenterology in 2011, having trained at RPAH and Liverpool Hospital in Sydney. He completed a clinical fellowship in liver medicine and liver transplant medicine at Mount Sinai Hospital in New York City in 2014. He is now a consultant gastroenterologist and hepatologist in Central Sydney and Western New South Wales, LHD. Mari has been a GP in Redfern for more than 20 years with experience and interest in aged and chronic care and Aboriginal health. Mari has also been an RACGP examiner for 15 years. I'll hand over to Mari now to take us through the learning outcomes for this evening.
Welcome everybody. We're hoping at the end of this activity that you'll be able to discuss the new hepatitis C treatments, their high cure rate and high tolerability, explain how to treat chronic hepatitis C in the GP setting with specialist support if required, and undertake follow-up to ensure the tolerability and efficacy of the prescribed treatment.
And so this slide illustrates the history of hepatitis C treatment in Australia and summarises the annual number of individuals with chronic hepatitis C initiating hepatitis C treatment over the last 20 years. And as you can see, as we move from left to right, we move from through the different eras of treatment, from standard interferon in the late 90s through to interferon with ribavirin, pegylated interferon in the early 2000s, and into the red bars where we see the use of interferon-free or direct-acting antiviral medications. So in total, over 61,000 Australians, or 26% of Australians living with hepatitis C, have been treated with DAAs. And prior to 2015, when these medications were listed or available on a trial basis, the rate of interferon-based therapy was averaging about 1 to 2% of all patients with hepatitis C being treated. So this is a significant change. So the challenge now is to maintain these really high treatment rates that we see to the right of the graph since 2016 and achieve hepatitis C elimination in Australia by 2030. And really want to stress that you as GPs have a really important role in addressing this challenge of hep C elimination. And it should be noted that there are no liver disease stage restrictions for prescription of hepatitis C medications in Australia. And looking at New South Wales data, in New South Wales from March 2016, when the new treatments were listed, through to September 2017, 20,000 people, nearly a quarter of the people living in New South Wales with hepatitis C, have accessed these treatments.
Oh, that's fantastic, Joe. So look, we'll go on to why we should treat hepatitis C. Look, there's really two broad benefits for treating this chronic infection: decreased transmission and improved clinical outcomes for the individual. So we're sort of looking at the public health and the individual benefits of treatment. So for the individual, curing hepatitis C, and that's what we mostly aim to do with these treatments, will reduce progression of the liver disease and increase liver-related and overall survival. For those with cirrhosis, there are other benefits, including reducing the risk of complications such as clinical decompensation, varicose bleeding, liver cancer, and the need for liver transplant. So all of those would really be a strain on the health system. Not all patients with cirrhosis will achieve all clinical outcomes or improvement, in particular those with decompensated cirrhosis. So you've got an argument there that treat patients with mild liver disease before they develop cirrhosis. So that's about really an early intervention in chronic hepatitis C, picking up cases and treating. There is emerging evidence that curing hepatitis C can improve patient-reported outcomes, such as quality of life, neurocognitive function, fatigue, and work productivity. Extrahepatic manifestations such as cryoglobulinemia, insulin resistance and cardiovascular disease also have potential for improvement with treatment. And treatment is easy these days. So the rollout of direct-acting antivirals has made treatment so much easier and well tolerated. Compared to the older interferon-based therapies, they have the following benefits. Easy administration because they're in oral form. Much better tolerability with significantly fewer side effects. A shorter course of treatment, 12 weeks in most cases, isn't it, Joe?
Yeah, that's right.
And less monitoring while on treatment. And, of course, higher rates of sustained virological response. That's cure at 12 weeks. Also, we now have great guidelines to follow, such as the Australian recommendations for the management of hepatitis C, a consensus statement you can see there. This all results really in an increasing number of candidates suitable for treatment, and it means GPs have a greater role to play in curing hepatitis C. So the next slide illustrates the increasing prescribing of these medications by GPs over 2016. So you can see that the proportion of individuals commenced on direct-acting antivirals by GPs increased from 8% in March to 31% in December 2016. In New South Wales, the increase was actually 54%, and this is great. And it is increasing because GPs are finding that treating hepatitis C really is straightforward with high patient tolerability. The latest percentage of hepatitis C treatment initiations by GPs in New South Wales, as I said, was 54%, and that was in 3 months from July to September 2017. So that's great. Look, there are times to consult with or refer patients to a specialist, but really there's sort of four basic groups, I guess, in a nutshell. Those people with cirrhosis, those with renal impairment, those with co-infection with hepatitis B or HIV, or those with a past treatment of hepatitis C. Those people, and we're talking about people who have had direct-acting antivirals and have failed treatment. So really they're the people that you'd broadly consider referring to a specialist. So you know, they're the four groups that I want you to bear in mind. So look, we might go on to the PBS requirements. They're pretty simple actually. We're dealing with adults, so the patient must be aged 18 or over. The treatment criteria is that it's by an experienced doctor, and we'll talk about that a little bit later. The information provided for the application must be the patient's Hep C genotype and their cirrhotic status, and the medical records must document evidence of chronic hepatitis C and evidence of the hepatitis C virus genotype. So we'll just go on to the PBS criteria. Experienced means that to start prescribing, GPs should have completed a formal education session such as this, and before prescribing independently, it's recommended that GPs consult with a specialist for at least 10 completed treatments through to cure. Look, this is a guideline, a recommendation. Some people might be extremely competent and start prescribing a little bit earlier than that, but that's the general guideline that, you know, is recommended people follow. So, Joe, we might go on to who should actually be considered for treatment.
Yeah, look, in Australia, all people that are living with chronic hepatitis C should be considered for treatment. The only exception would be those that have a limited life expectancy of less than 12 months due to non-liver and non-hepatitis C related comorbidities, such as a disseminated malignancy, for example. And again, reminding you that there are no liver disease stage restrictions on PBS in terms of cirrhotic status.
So somebody with quite advanced cirrhosis should still be considered.
That's right, and remember that's
yes,
going to be
yes.
considered in a specialist
setting. Yes,
and most of the patients that we're talking about here in Australia living with hepatitis C don't fall into that. So most in the community have don't have cirrhosis and can be treated within the context of general practice.
Yeah, there was a question. Should you wait 6 months for every patient to be diagnosed and treated, given that we're supposed to be treating people with chronic hepatitis C?
Look, that is part of the PBS requirements, but I think rather than having it just depending on 2 HCV RNAs separated by 6 months to define chronic hepatitis C, you can use a clinical judgment in terms of your history. So looking at how long risk factors have been present. So if the risk factors have been present for the infection for 10 years, 20 years, and there's been persistently abnormal liver function tests, I think it's reasonable to diagnose chronic hepatitis C in that setting. Okay. But if someone's quite young and they have no evidence of cirrhosis and they have only just recently been at risk of the infection, then that might be a time when you would watch and wait for 6 months.
Because if they have an acute infection, they can get over it,
can't
they?
No,
yes,
up to a quarter to a third of patients can clear the virus spontaneously.
Yes. Okay.
So that's the rationale.
Yeah. Oh, great. Look, well, we might go on to discuss the new hepatitis C treatments, their high cure rate and their high tolerability. So this slide here, now don't be frightened, it shows the brand names for all interferon-free regimes currently listed on the PBS. These are the ones that are on the market and they can all be used to treat different patients depending on their needs. But generally GPs will be using Epclusa, the one on the left. And Joe, just tell me what that's a combination of, because I just can't quite get my tongue around it.
So that's a combination of sofosbuvir and velpatasvir. It's 2 drugs in one pill, so it's a fixed dose combination pill that covers all genotypes 1 through 6. So that really simplifies treatment choices in community practice.
And it's 1 tablet daily for 12 weeks, isn't it? So they get 28 correct. And 2 repeats.
That's correct. Yeah.
Okay, so Joe, the next slide I think you could have a look at.
Yeah, so I just thought, because there is that overwhelming number of treatments available on the PBS, and I just wanted to point out that in terms of clinical efficacy, they're all pretty equivalent for the type of patients, the non-cirrhotic patients that are being treated in general practice. So the cure rates are greater than 95% with all of the DAAs across the genotypes for non-cirrhotic patients. So I think we just keep pointing out the Epclusa regimen because it's an easy one to remember. It's pangenotypic, and there are a few restrictions in terms of renal failure, for example, but which we cover later in the talk.
Okay, great.
So in terms of the treatment options, as we were just saying, for all hepatitis C genotypes, you can use a pangenotypic regimen that's effective across all those genotypes. And at the moment, the drug that's listed that falls into that class is the sofosbuvir-velpatasvir combination, which goes under the brand name of Epclusa. But there are more pangenotypic regimens likely to be listed this year. Okay, and again, remembering that the DAA cure rates for non-cirrhotic patients exceed 95%.
Oh, that's great, isn't it? So I guess, look, we'll discuss the potential side effects because they're pretty much minimal and, and so they really are tolerated well, aren't they? So the box on the right there relates to treatment regimes containing ribavirin. So that's really what specialists are going to be dealing with mainly, isn't it? So on the left, the medications the GP can expect to prescribe are listed there, and the top one is the one that we're going to be mainly using. Yeah. Look, they've got high tolerability with the potential for mild and sort of non-specific side effects, and they can be used in all genotypes, but the top one, Epclusa, is going to be the most likely. So these sorts of symptoms, how often are you seeing those sorts of symptoms, Joe? Headache, fatigue, nausea?
The headache comes up fairly frequently, but it can be managed with simple analgesics like paracetamol and anti-inflammatories. The fatigue, I haven't seen a lot of. Sometimes GI upset is mentioned, but if you encourage patients to take their medications with food, you see that less. And nasopharyngitis is something that's been listed on as a complication of the Epclusa treatment, but I've not yet seen it in patients.
And what proportion of people would stop treatment?
Less than 1%.
Less than 1%.
Very different to the interferon era.
All right, great. So we might go on to explain how to treat chronic hepatitis C in the GP setting, of course with specialist support if required. So we've got, we're going to talk about the essential steps. Basically, let's walk through the major steps in treating an adult with chronic hepatitis C. So firstly, determine the genotype. Now you need this for PBS prescribing, and the viral load. Quantitative is requested for genotype 1 because sometimes a shorter course of treatment can apply. Also, you should get baseline blood count and biochemistry. We did mention renal function before, and check other serology to determine comorbidities and assess the need for vaccination. Secondly, assess for cirrhosis and refer, if present. Also refer those with renal impairment, co-infection, or if they've had past treatment with DAAs. Next, select the regime. Remember, there is that genotypic regime. Then check for drug interactions. The list of prohibited drugs is relatively short, and we will go on later to show you how you can access information easily on checking for drug interactions. Then you monitor on treatment and hooray, check for cure at 12 weeks. And then follow up as required. So the next slide will further explain some of these points. Joe, would you be able to sort of go through?
So look again, and this goes through the PBS requirements and the essential information that you need to prescribe these medications. So as we've said before, we need to identify current chronic hepatitis C infection, but with the presence of the HCV RNA in the blood. And quantification can be useful in genotype 1 infections. If it's low, you can qualify for half only with a truncated duration of 8 weeks treatment. And of course, genotyping is a PBS requirement. Whilst it doesn't impact upon your treatment choice with the pangenotypic regimens, it is a PBS criteria. You also want to determine the impact that the hepatitis C has had on your patient, and basically assessing whether a patient has cirrhosis or whether they do not have cirrhosis. And that has implications for the context in which they're treated and also their care post-cure. So it can influence the treatment duration and regimen and whether ribavirin's added. And it also identifies people who need to be screened for the complications of cirrhosis, like hepatocellular carcinoma or even portal hypertension and gastroesophageal varices. Now, it's important to identify whether somebody's treatment naive, people who have not been treated or treatment experienced. And if they have had treatment before, sort of work out why they've failed or whether they've been reinfected. And as we've said, if they've failed direct-acting antiviral therapy, they need to be assessed and treated within the context of a specialist care.
Just somebody had a question about hepatitis B reactivation, and what should sort of GPs know about this in terms of treating people with hepatitis C on treatment?
Look, there has been some evidence of hepatitis B reactivation in patients, mainly that are surface antigen positive. So when you're screening your patients before treating with the direct-acting antivirals, if you identify a surface antigen positive patient, they should be referred through to a specialist clinic. So there are different ways to approach that problem. Some people may need treatment of hepatitis B simultaneously, or if they're low risk, just monitored through treatment, looking for a hepatitis B flare.
And say somebody's found not to be immune to hepatitis B, should you delay treatment?
Not at all, not at all. I think it's a really important point. If you've identified somebody that's susceptible to the infection and they already have a chronic viral hepatitis, you want to get on and protect them. So don't delay initiating the course of vaccination for hepatitis B, and you can safely vaccinate and treat the hepatitis C.
Great, okay. So no interaction there.
No.
Good. Okay, so here we've got a reminder about pre-treatment assessment, really going back to basics. So take a good history, examine the patient, get them up on the couch, and arrange appropriate tests to assess the likelihood of cirrhosis and other comorbidities. So the history should document risk factors for the progression of liver disease, such as HIV, hepatitis B, diabetes, obesity, fatty liver. Also ask about alcohol use And medications. Take a good medication history because you want to assess the hepatotoxic drugs and potential interactions with the hepatitis C treatment. The past treatment for hepatitis C should also be noted if it's occurred and refer those people. The baseline bloods and non-invasive tests to assess fibrosis are really part of this assessment and include renal function, full blood count, coags and liver function tests. Renal impairment and co-infection should prompt specialist referral, as previously mentioned. There's no real single way to diagnose cirrhosis, and liver biopsy is not frequently performed. So the next couple of slides should address this issue. An ultrasound is preferred over CT scan if you're going on to other imaging. An ultrasound is preferred as a first-line test above CT scan, say if the FibroScan is unavailable or if there's a need to further assess for cirrhosis or liver lesions. If the ultrasound is supportive of cirrhosis, additional confirmation is not really needed. A liver biopsy is sometimes needed, but how often do you find, Joe?
It's pretty rare.
Yeah.
I mean, and it used to be a requirement to access hepatitis C treatment, but not for many years, and it's certainly not part of the treatment algorithm now. But sometimes you will have rare patients that it's really difficult to establish whether they have cirrhosis or not.
So the first 4 boxes on this slide are the way that, is generally the last 2 are really sort of in special circumstances, aren't they?
Absolutely.
All right then.
So this slide just illustrates or reinforces the need to establish a diagnosis of cirrhosis in patients before they're being treated, because it has implications for future prognosis. It determines the urgency for treatment to prevent complications and progression of cirrhosis from compensated to decompensated disease. In some cases, it can determine the treatment regimen and duration and the addition of ribavirin, for example, in a specialist setting. And as we said before, the diagnosis of cirrhosis does prompt further investigation of complications of cirrhosis, like liver cancer and portal hypertension.
Yes, sure.
And just reinforcing that, with the diagnosis of cirrhosis, lifelong surveillance is required with 6-monthly abdominal ultrasounds and serum AFPs.
Yes, okay.
For early diagnosis.
Yeah, good. So we'll go on to fibrosis assessment and the APRI score. So the APRI score can assist with assessing the degree of fibrosis, especially if a FibroScan, say, is not available. It can assist in excluding the presence of cirrhosis. So an APRI is calculated using the patient's ALT level and platelet count and the lab's upper limit of normal of the AST. So the lower the APRI score, say less than 0.5, the greater the negative predictive value and therefore the ability to rule out cirrhosis. So a low score is a reassuring
result that can direct you to treat within general practice.
Okay, so then the higher the score, greater than 1.5, let's say, the greater the positive predictive value and the ability to rule in cirrhosis. Now, mid-range values therefore are less helpful as they do not accurately differentiate intermediate fibrosis from mild or severe fibrosis. So the APRI alone is likely not sufficiently sensitive to rule out significant disease if it's in that mid-range.
But we do use that cutoff of less than 1 as a reassuring sign.
Yes. So somebody asks if the APRI is less than 1, is a FibroScan still needed?
Look, it depends. If you have the FibroScan available, you can utilise that in terms of completing your assessment.
Okay.
You can also use your clinical acumen in terms of your history and your estimation of the risk of cirrhosis. So if there's been a long duration of infection, there's been lifelong alcohol use, that can increase your index of suspicion. Yes. And you can also utilise those other modalities that we talked about, such as abdominal imaging, looking for imaging evidence of cirrhosis, or if you're really uncertain, proceeding to liver biopsy, and if that is the case, sending on to a specialist clinic.
Well, you can also have fluctuating levels, can't you, of platelet numbers and
also with the fluctuation of the liver enzymes.
Yes,
that's correct.
Yes. So a FibroScan's a good thing, isn't it?
That's right.
So why don't we go on to FibroScan?
Yeah, so a lot of people will now be familiar with what FibroScan is. The availability has increased around the state. Now, for those that are unaware, the FibroScan's a painless ultrasound test that just takes a few minutes to perform by the bedside. And an ultrasonic wave is transmitted through the liver and reflected back to the probe, and calculations are made on the velocity of that wave. And the stiffer the liver, the faster that wave will travel through. The stiffer the liver, the greater degree of fibrosis and cirrhosis. So it is a very useful test when the score is very low and you have a very soft and supple liver, and scores less than 7. It's very good when the scores are very high at ruling in cirrhosis. But again, like the APRI, there's that grey zone in the middle, that it's not great at differentiating between intermediate and moderate fibrosis. But very good at determining whether somebody has a normal liver or a cirrhotic liver.
So there's a question here. If the APRI or FibroScan suggests fibrosis, what's the role of sonography there?
Well, as we said, like if you use sonography as well, you can find cirrhotic changes in the liver. So you might find a small or nodular liver, you might find a dilated portal vein, and other evidence of portal hypertension that can build a case of a diagnosis of cirrhosis.
Okay. So we'll talk about selecting the appropriate treatment regime. And these are the main considerations for determining that regime. So define the HCV infection. So make sure you know the genotype and the viral load. Assess for cirrhosis, renal failure, co-infection or past treatment, and refer if present. Assess for other comorbidities and assess medication use, noting the risk of drug interactions, and provide the patient with adequate information to make decisions on treatment. So treatment of hepatitis C can be guided through current PBS listed treatments and management recommendations. So you've got great guides here. You can get information on hepatitis C treatment in Australia from the General Statement for Drugs for the Treatment of Hepatitis C. And this is always up to date. So it lists the patient eligibility conditions and prescribing restrictions, and the treatment matrix is available for PBS prescription. And other resources, the Australian recommendations for the management of hepatitis C virus infection, a consensus statement, but that can be delayed in terms of the updates. So Joe, this looks fairly complicated. Would you simplify this slide for us?
That's right. And again, this slide illustrates all of the treatment options that are available on the PBS that you can prescribe. The top row, highlighted in the grey, is that sofosbuvir velpatasvir fixed dose combination regimen called Epclusa. So just want to stress that that's the go-to drug for treatment in general practice in a non-cirrhotic population without renal failure. But there are a couple of things that might preclude you from using that treatment regimen, and drug-drug interactions is one of those reasons that might not allow you to use that medication in your patients, and also comorbidities. And we've mentioned renal failure a few times. We cannot use sofosbuvir-based therapies with people with a GFR of less than 30. So again, busy slide, but it's just illustrating the breadth of the treatment options, but highlighting that sofosbuvir and velpatasvir can be used across genotypes in many patients.
Okay, so I'm going to ring up and get an authority. Oh, I'm nearly there, aren't I? Okay, so I've chosen the appropriate regime. I think I'll go with Epclusa, and I'll obtain a PBS authority to prescribe. I'll generally require a 12-week course, so 28 and 2 repeats. And when I ring the number, I'll be asked the number of weeks of treatment, so that's 12. They meet the general statement, yes. The genotype, well, pick one because I'm going to use the pangenotypic regime. And cirrhosis or non-cirrhosis, I'm going to treat the person with no cirrhosis. So that's pretty straightforward, isn't it? Okay, so now we've got the patient on treatment. Now, they do say that you recommend 100% adherence. Yes. So, look, it's important, I guess. Adherence is important to ensure the success of the treatment and to reduce development of resistance. You aim for 100%, but occasional missed doses may not affect the treatment outcome. Any idea how many missed doses are important, Joe?
Look, I think we've always got to stress to our patients that 100% compliance is desirable for treatment success and avoidance of viral resistance. But there is evidence coming through with post-marketing data that several doses can be missed, but we don't want to tell our patients that.
No,
we'll
keep that to ourselves.
That's right. We want to make sure we maximise the number of doses. And there are many strategies that you can use to optimise that.
Yes. Okay. So some of the strategies highlight the benefits of the treatment to the patient, explain why they're being prescribed the medications, what can be done to achieve a cure, and what happens if doses are missed. So what does happen if a dose is missed?
Look, I mean, if you remember within 18 hours, you can take the pill that day, but never double dose.
Okay. So do you extend the duration of treatment? Somebody's asked if there have been missed doses.
No, I think you just you just continue the treatment until all pills are taken.
Okay. Yep. All right.
So if that's beyond your estimated treatment duration, then you just keep going till the pills are gone.
And on the right, there's just a box there to remind us about different ways that you can improve adherence, so using dosette boxes and reminders and supervised dosing. And there's also the NPS Medicine Wise app. You look up the NPS and you can find some good resources for improving medication adherence. So drug-drug interactions, Joe. Gee, that looks a bit complicated too.
It doesn't need to be complicated.
Okay,
and I think if everyone utilises this website, which is listed at the bottom of this slide, it's the Liverpool University in the UK. You can www.hepdruginteractions.org. And very simple, easy to use. You punch in the regimens that you would like to use and the medications the patient's being co-prescribed, and you'll come up with a traffic light system. So green is go, no worries, no interactions. Amber is used with caution, and red is incompatible, cannot use the co-prescribe the medications. In terms of the medications that cannot be co-prescribed across the board, it's carbamazepine and some of the other anticonvulsants. So sometimes you might need to either find an alternative regimen or talk to a neurologist and find alternative anticonvulsants.
And sack the herbalist.
Often you can do without St John's wort.
Yes. Okay.
With the amber alerts, if you click on that amber box, you do come up with some advice on what to monitor and strategies to deal with potential interactions.
Oh no!
So utilize this. Utilize this website.
Easy to use.
Absolutely.
Yeah. Okay. So let's look at the type of scenarios you might get caught up with here as a GP. So GPs can commence treatment with specialist approval until you're experienced. As we said, about 10 completed treatments through to cure. You can prescribe independently once you're experienced. You can refer complex patients to specialists, so people with renal impairment, infection, people who have failed previous treatment, and those with cirrhosis. And you can share care with specialists or clinics depending on your level of experience and confidence. So you might be part of a team supporting the patient with lifestyle advice, monitoring and preventive health measures such as immunisation updates. So you can really be involved across the spectrum anyway. So gaining specialist approval, if you're not experienced in hepatitis C, is it's assisted by some forms that you can use. So look, it can be as informal as finding a specialist who's quite happy to work with you and making it via the phone But you can actually use special forms here to seek approval from a specialist, and the form sort of acts as a bit of a checklist too, doesn't
That's
it?
Right, a bit of a reminder of the things you need to consider when you're treating hepatitis C.
Yeah, so that looks good. That's the remote consultation form. And there may be localised pro forma in your area, so it can be downloaded there from GISA. But there's another form, isn't there, that we go onto the next slide.
Yeah. So the Kirby Institute in Ascham are looking at real-world data, or collecting real-world data on the uptake of these medications in Australia, and you can utilise the study to get your specialist approval. So by completing this online form, which you can see illustrated on this slide, which is accessible through the REACH-C at ascham.org.au, you are consenting for patients' de-identified data to be entered and collected for that REACH-C study. There are requirements to enter your SVR data, so the 12-week post-treatment data on treatment success. But it can be a good resource for people that don't have easy access to specialist consultation, and particularly those in the regions.
And are you finding people are using these remote consultation forms and things like that?
Yes, sometimes, but I mean, they don't have to be used. A consultation can be a corridor discussion. It can be an email to a specialist that you know.
I guess if you've got a good working relationship with the GP.
Absolutely. And, the PBS has not defined what that consultation means.
No. Okay. All right. Oh, that's great. So, undertaking follow-up to ensure the drugs are tolerated, that they're working. So we'll go over the overall on-treatment monitoring for the direct antivirals is less intensive than what was required for interferon-based therapy. Each practice or GP can develop a system to enable it to be done routinely. Remember to assess for treatment adherence at each visit. So as you can see, after 1 month of therapy, check the LFTs and ask the patient about adherence and check for drug interactions and tolerability. So they're the basic steps that are required. There are some specific monitoring steps for certain regimes. So people treated with Elbasir plus Grazoprevir should have liver function tests at week 8 to screen for hepatotoxicity. So they can be done as an alternative to the week 4 LFTs, can they? If they're on that particular medication, Joe?
Yeah, that's correct.
Okay, all right. Then routine on-treatment Hep CV RNA testing is not mandated, but may be considered where there is a clinical concern about non-adherence to treatment, especially in people with cirrhosis. Do you do that much?
Yeah, it can be. Yeah. I mean, if your liver function tests aren't improving when you're assuming someone's on treatment, it can help you answer that question.
Right. Okay. So, but for GPs, it's generally at week you've had your baseline test, and at week 4 you check the LFTs and check their adherence, check for drug-to-drug interactions and any adverse effects. Then at the end of treatment, check their liver function tests, and then 12 weeks post-treatment.
Yep.
Their liver function tests and their HCV RNA, and you're looking for a cure.
Yep,
you don't want any RNA,
that's correct.
And that's RNA to be detected.
That's the definition of cure. So absent or undetectable HCV RNA 12 weeks after treatment completion, that is cure.
So sorry, can we just go back there? So at week 4 weeks after you start treatment, LFTs, at the end of treatment, LFTs, and then 12 weeks after that, look for sustained viral response. So it's a 24-week follow-up.
That's correct.
Basically. Yeah. Okay. Yep. Okay. Thank you. So 24-week follow-up to confirm cure. So the sustained viral response at 12 weeks post-treatment completion is a cure. So there's undetectable HCV RNA. This test does not need to be repeated if there are no ongoing risks. If the risk of reinfection is high, you can repeat testing yearly. Note that the HCV antibody test will remain positive after cure, and it shouldn't really be repeated. So warn patients that this happens, and because if they get the test done by another doctor, they might think they've got hepatitis C again. But that's the antibody, it will remain positive in most circumstances. Treatment failure is where there is still detectable HCV RNA 12 weeks post-treatment completion. So at 24 weeks after the beginning of it all, that they shouldn't have it.
Yep.
That's going to be a small percentage of patients,
That is
isn't
correct,
it?
yeah.
Okay. So post-treatment follow-up. Now, this is in people with no cirrhosis. So these are the people that GPs are generally going to be treating. You're looking for a sustained viral response at 12 weeks. Now, if they've got normal liver function tests, they don't need any regular follow-up unless there's an ongoing risk of reinfection. If they've got abnormal liver function tests, I think refer them to a specialist.
Yeah, because you need to think about other liver diagnoses that might be coexisting.
Yes. Now, if there's no sustained viral response at 12 weeks, we'd refer them off.
Yep.
Yeah. Okay. Yeah. All right. Thank you.
And so in terms of the cirrhotic population, we just thought we'd throw this in for interest.
Good.
So the SVR12, the cure, is assessed at the same time point, so 12 weeks following the treatment completion. And these patients cannot be discharged back into the community. They need to be monitored because they have been diagnosed with cirrhosis. And we've said before, looking out for hepatocellular carcinoma with 6-monthly liver ultrasounds and serum alpha-fetoprotein, screening for esophageal varices with upper gastrointestinal tract endoscopy, so gastroscopy to assess there, looking for osteoporosis complicating cirrhosis with 2 yearly DEXA scans, and looking at vitamin D levels, and then looking up for evidence of decompensation, so progression of the cirrhosis from compensated to decompensated with ascites and cephalopathy, variceal bleeding, peripheral edema. And just the point down the bottom, like monitoring the severity of the decompensation with scores such as the Mellon score or Charles-Pugh score, and considering interventions such as transplant if need be. So we just also wanted to, we've mentioned before that there are some new pangenotypic regimens coming through the pipelines, which are not listed on the PBS at the moment, but both have been TGA approved. So it's just to point out. So there'll be a medication, a combination, fixed dose combination of glysaprevir and pibrentasvir that will be able to be used in renal failure. And then there's a retreatment option, a fixed dose combination pill of sofosbuvir, velpatasvir, which is they're the 2 drugs in Epclusa, but with doxorubicin added to that.
An extra long word in there. Yes.
That's correct.
Yep.
But they'll be for retreatment for DAA failures.
Yeah. Oh, gee, it's moving along, isn't it? Really.
At a pace.
So look, let's just summarise those essential steps in treating hepatitis C, because look, it's easy. You're going to cure these people, and so get into it. So remember, treatment is straightforward and well tolerated, and most patients are suitable for GP care unless they basically got cirrhosis, renal impairment, co-infection, or past treatment. The monitoring has been simplified and information is readily accessible for checking for drug interactions. So test them for hepatitis C, their genotype and their viral load, do your baseline tests, exclude cirrhosis, establish prior treatment experience, check, select your regime, check for drug-to-drug interactions, monitor them on treatment with LFTs at 4 weeks, then LFTs at the end, and then 12 weeks after treatment, check for a sustained viral response at 24 weeks, that is, so 12 weeks after treatment is finished, and then follow up according to the recommended guidelines. So in order to really consolidate what we've been talking about and learning tonight, we'll do this case discussion, and we're just going to talk about Jake, who's a fairly typical patient that you could expect to come across. So he's 58, unemployed. He's used amphetamines since 1985 and still injecting occasionally, minimal alcohol use. You've tested him for his genotype and it's G3A. He's got a past history of reflux and he's treated with esomeprazole, 40 milligrams a day, and he's a thin build with a BMI of 20, no signs of cirrhosis. So, Joe, what other assessments do you think we'd need?
Look, I think we need some other investigations to look for renal failure,
Yeah.
look at his liver function tests and full blood count and INR to looking for evidence of liver disease. We do need to establish whether he has cirrhosis or not. So
Yes.
I'm thinking about utilising what
Definitely.
non-invasive tools we have, like the
Yes.
APRI and FibroScan.
Yes.
That's the next step, I would think.
So we'll presume we've done the full examination of him, and clinically we don't think there's any cirrhosis, but we'll do the APRI score. So the basic bloods will include biochemistry, including renal function, LFTs, as you said, and haematology. Here, the APRI score has been calculated for us, and it appears quite low, much less than 1. So, Jo, how would you interpret that?
Look, it's pretty reassuring.
Yes.
It's quite a low score, and I think that we could be reassured that this gentleman does not have cirrhosis.
Yes, okay.
But we might want to confirm that with further investigations.
All right, okay. Well, all right. Well, luckily, our local hospital has a FibroScan service available. And here we have his results. He sits just below the cutoff there at 7. So he's got mild cirrhosis, doesn't he? Mild fibrosis, I'm sorry.
No,
Yes.
I mean, that's a pretty low score. So we use less than 7 as no significant fibrosis. So yeah,
Okay.
a score of 6.2
All right.
kilopascals would consider normal.
So mild or absent fibrosis is likely, and the low APRI score, we're saying that we don't really think fibrosis is an issue here.
Yeah, no,
Okay,
that's correct.
all right. So it would appear he's at low risk for liver disease progression.
If we get rid of his Hep C.
Yeah, if we get Hep, that's what we have to do, isn't it?
That's right.
Okay. So what we need to know about Jake. Okay, so the date of infection is, well, he started using around 1985. So
yeah, we use that first risk factor as the marker.
Yep. Okay. Good. Okay. We know his genotype, and the viral load is
2.3 million.
Does that mean anything?
Not in this context.
No. Okay. Because we're going to cure him anyway. No evidence of cirrhosis.
That's correct.
So it's a low level or absent fibrosis. Liver comorbidities, no. He's not overweight, doesn't have diabetes.
And doesn't drink a lot of alcohol.
But he does have other comorbidities, gastroesophageal reflux. He's on esomeprazole and amphetamine use. No signs of co-infection. No previous treatment for the hepatitis C. So what's the plan? Okay. So can Jake be treated in the primary care setting?
Yeah, we've got a gentleman who's got chronic hepatitis C. He's got no evidence of cirrhosis. Some people might be concerned about his ongoing amphetamine use, but it's not an absolute contraindication to treatment. I mean, in fact, if he's turning up to seek help, he's attending your general practice, and if you can engage him and he doesn't have a chaotic lifestyle that can sometimes go with ongoing amphetamine use, it's very reasonable to treat, and in fact, it's desirable because we can reduce the risk of transmission. within an injecting drug population.
So when is it a barrier to treatment, ongoing injecting drug use?
Well, as I said, when injecting drug users' lifestyle is chaotic and they may not remember to take pills, they might not have their blood tests done, that makes it very difficult to treat those patients. So,
yes.
Ongoing injecting drug use is not a contraindication, but it's a precaution. It's something to consider in your assessment.
Okay. So what are the treatments options available for Jake, and what duration?
Well, if you go back to your previous slide, you can see that there's a few treatment options open to him, and we've got a gentleman with genotype 3 who's not been treated before, has no evidence of cirrhosis. So we could look at the tabulated form of the treatment options for all hepatitis C. So, of course, he can qualify for the pangenotypic regimen with sofosbuvir and velpatasvir, and with a treatment duration of 12 weeks. But he also qualifies for the sofosbuvir and decladisvir regimen. So it's still sofosbuvir based. We would not need ribavirin in this setting because he doesn't have cirrhosis.
Yep.
Again, it's a 12-week duration, but it's 2 pills to take. As opposed to 1. So the only difference between those, I mean, they're equal in efficacy, but slightly simpler treatment regimen. Only 1 pill to remember to take rather than 2.
Okay, all right.
And look, I should have mentioned too. We do need to think about drug-drug interactions, and we've already assessed that he does not have renal failure, so we can use these sofosbuvir-based regimens. But there might be something that pops up on.
Yes, he's on this esomeprazole. So.
So look, I think if you don't have to remember all the drug interactions off the top of your head, and always stress the importance of using this website and assessing the drug-drug interactions. So if we look at esomeprazole,
so this is how it comes up.
Yeah,
sorry, Joe.
Exactly.
Yeah,
Just going back, you put in the treatment options that you have. You can see decladisvir, sofosbuvir, and then the sofosbuvir velpatasvir combination.
Yes.
So esomeprazole is compatible with the decladisvir and sofosbuvir combination, but you get an amber alert for the Epclusa tablet.
Yeah, and
here it comes. And so when you click on that amber alert, it'll give you the risks and the things to look out for. So it's not the end of the road. It's often people are on proton pump inhibitors and they can actually stop them.
Yes.
And their reflux may not be a problem requiring ongoing treatment. So that's the first strategy to use. But you can actually, and as prompted by this website, you can use a low dose of omeprazole, Losec, separated from the DAA dose or the Epclusa dose by 4 hours. So there are other strategies.
Yeah. So ranitidine would also be
famotidine and low dose.
Yes.
Yep.
Okay. Yes. Okay.
So
review
again,
the need.
That's right. So in this situation, we've got the gentleman who's on esomeprazole. You review the indication for the proton pump inhibitor.
Yeah.
And
we don't do that often enough.
That's true. And consider stopping the PPI or switching to an H2 receptor antagonist like famotidine or ranitidine if you're wanting to use the Epclusa. And you can use omeprazole at a 20 milligram dose, 4 hours separate from the Epclusa dose.
In somebody like this, would you maybe do, check them for Helicobacter and maybe treat before you?
Certainly something to consider. It depends on the clinical context.
Yes, sure. Okay. So in this instance, we'll say Jake has had treatment with the Epclusa for 12 weeks. So let's talk about the testing that needs to be done at the end of treatment. So at 12 weeks?
At 12 weeks, we need to look at his liver function tests, and hopefully they're normal.
Okay, and so does he need any further testing beyond that?
Look, we've got to remember that completing the 12 weeks of treatment is not the end. We do need more testing in another 12 weeks.
Yes.
So 12 weeks post treatment completion. So looking for the hepatitis C RNA in the blood and also the liver function tests.
Yes. Okay. Well, here he goes. He has had a sustained viral response, so he's been followed up at 24 weeks, and his liver function tests are normal. So does he need any further follow-up for HCV?
Look, I mean, we've confirmed that he's non-cirrhotic, so from that perspective, he doesn't need ongoing follow-up. But remember that he does have ongoing injecting drug use behaviour.
Yes.
So he's the sort of patient that we would need to look out for reinfection. Okay?
Yes.
Remembering the hepatitis C antibody may remain positive for the rest of his life. So checking the HCV RNA 1 or 2 times a year to see if he's been reinfected.
Yes. Okay, so that's one of those special cases.
That's right.
So, look, here's some really good resources because, look, keep them, put these up as your favourites because we've given you a lot of information tonight, but there's a lot of support for prescribers and the community out there. So Asham has e-learning Up there you can see an NPS Medicine Wise has e-learning, and as I said previously, they've got ideas on adherence strategies as well. MD Briefcase e-learning as well. And then there's specific hepatitis C resources through GESA, ASHM and ACID, so those resources are up there too. Now, don't forget that the patients need a lot of support. Some people will be more interested than others, but try and link them in with Hepatitis New South Wales. There's also a hepatitis information line, and it's important that they can access information and support services in the community. Then there's GP practitioner support. There's a directory of local doctors prescribing HCV and dispensing pharmacies. And there's information and resources for GPs, as you can see, with these two sites here.
Yeah. So look, I think in terms of wrapping up the talk and summarising what we've been through today, we want to stress that T is for test. Screen everybody that's at risk for hepatitis C, and remember that hepatitis C can be cured in most patients. And confirming hepatitis C means patients have the hepatitis C antibody and the RNA present in the blood.
Yes.
So consider treatment for all people, including people that inject drugs.
Yep. So we've got to assess them for liver fibrosis and other comorbidities. So make sure you do a really good assessment leading up to treatment, and refer patients off if they have cirrhosis, renal failure, co-infection, or they've had previous treatment. So you can share the care with the specialist, but you do need specialist input and advice and management for those special categories.
Remember to evaluate for drug-drug interactions and utilise that online resource, the hepdruginteractions.org, and that's going to help you select your appropriate regimen. Okay. And remember to assess adherence throughout your course of treatment.
So when you start prescribing, get approval from a specialist to prescribe. You can use the remote consultation request form that we discussed, and that's for you to build up experience in hepatitis C treatment. And they can get the scripts dispensed from a community pharmacy, so you just need to go through the authority line, as we said.
Okay. And our aim is to treat all people with chronic hepatitis C. We monitor them on treatment and remember to check their SVR 12 weeks after treatment completion. You can tailor your post-treatment follow-up according to the treatment outcome, the liver disease stage and reinfection risk. And remember that patients with cirrhosis need ongoing lifetime surveillance for liver cancer, and it should be managed in a specialist setting. And retreatment can be offered to people who can't become reinfected, so don't give up then.
No. Well, look, we hope that's been really helpful. So, look, this presentation was developed by a cohort of great organisations. So, ASHM, the Australian
Society for HIV Medicine.
Yeah, good, Joe. And the next one, Joe?
The Australian Liver Association, as part of the Gastroenterological Society of Australia, and the Australian Society of Infectious Disease. We know the RACGP,
I hope so.
and also the wonderful Kirby Institute.
Yeah, okay. So we'll go through now the learning outcomes. I think we should have managed them. We're hoping that you should be able to discuss the new hepatitis C treatment, their high cure rate and high tolerability. Explain how to treat chronic hepatitis C in the GP setting with specialist report, if and as required, and undertake follow-up to ensure the tolerability and efficacy of the prescribed treatment.
Great. That brings us to the end of this evening's session, everybody. I'd like to thank Joe and Mari again for joining us, and I hope you all enjoy the rest of your evening.
Good night, everyone.
Good night.